Aidin has recognized that importance, and I just want to acknowledge you and your organization for the importance of this conversation and the importance of really taking a look at strategies and practical response to what has become probably among one of the most pressing parts of the health system. So, Akanksha, on the behalf of the panelists and the participants today, our thanks to you and to your organization. And with that, I just want to jump in. My name is Gil Bash. I am honored to moderate this conversation today. I'm honored to join with us three national experts in health. Just before we begin, I just want to acknowledge that all of us who are part of this call today have tremendous commitment to innovation that can improve human health. And we have behind us incredibly dedicated health professionals. And we recognize more than ever that we have to have a keen eye toward creating value-based care. Value-based care that delivers for health professionals, for providers, for payers, and most importantly, for the people we serve, patients. We're always people first and then patients, but at some point, we're all patients. And I think our people recognize that. Can everybody hear me clearly, by the way? I just want to check. Yes? Yeah, I thought so. Okay. Someone had said, one of my hosts had said that my mic might be muffled, but it might be a connection. But can everybody hear me clearly?
You're a little muffled, Gail.
Okay. That might be a little better. Thank you.
That's better.
So, thank you. So I just want to say that what we've learned most certainly in the past 2 years, is that contrary to initial thinking, patients with a higher length of stay actually have often a higher likelihood of being readmitted to a hospital. And that, I can see Marcia's nodding away on that. She's really one of the thought leaders who's been looking at that very closely. And thank you, Marcia. And in our next 50 minutes together, we're going to explore strategies and practical solutions to ensure that amazing patient care will address readmission. And we'll see what these three leadership colleagues are doing in the field. So let me introduce you to our colleagues. I'm going to do it in alphabetical order by last name.
Gil,
Akanksha, you look like you want to say something.
Yeah, I was just going to ask, can we pause for about 5 minutes? I anticipate people will start, there are people we anticipate trickling in and starting at about 5 o'clock, if that's okay with you.
Absolutely. Absolutely.
Cool.
In the meantime, our participants, I want to invite them to use the chat function to raise questions, and I'll be monitoring the chat. Many of you, while we're waiting to begin officially, many of you have been sending us questions in advance. I want to make a pledge that we'll do our best today in the hour we have to address almost all of those questions. They are important, particularly because Paul and Marcia and Lisa, I'm going alphabetical order to your last name, by the way, have really been in the trenches addressing many of the questions. So this is going to be a very practical conversation. So if you have additional questions, don't hesitate to use the chat function. I see those questions. I have a pad and a note. I will take them down. We'll do our best to weave them in. For those of you who are just joining us now, I just want to say that our panelists are dealing with in many cases, like Marcia, are dealing with a real live public health crisis. It's fluid. They occasionally will have to go to mute and jump and take a call. I think we can be forgiving and appreciative that they are doing what we all do best. They're putting patients first. So I want to thank all of you. If you have to take a call, you're all on automatic mute, so don't worry about that. But at the same time, I believe that this is being recorded. And the recording, Akanksha, will be shared, I imagine, publicly and available to everybody. So if you miss a little piece, please don't worry. We'll be sharing the recording with everyone who is registered today. So with that in mind, we still have 3 minutes to go. And I want to be respectful for people who are very clock conscious. So we're going to wait those 3 minutes. If you'd like to grab a cup of coffee or a drink beforehand, please do. An hour with three people that we have, our three panelists, Paul and Marcia and Lisa, will go very fast. So grab something now, and in about 2 minutes, we're going to jump in. Well, before we're beginning, though, unofficially, I just want to ask our colleagues. They've been in the office, obviously. So before we begin, I'm going to ask an open question to our panelists. In the last 16, 17 months, have you had much of a life? As they smile away. Paul, how's your life been in the last 16 months? Busy much?
Yeah, it's been a year of innovation, a year of turmoil, but it's also, I think, brought myself and my team closer together in ways that we didn't know that we could be, in trying to find different ways to do things. And so I think innovation is probably the biggest thing that we have found that we can use in a lot of stress, but we have found ways to overcome a lot of those kind of problems that we've overcome. We've had to face those barriers. It's been incredible how many people have come up with ideas to do things that we didn't think we could do. And banding together, not just us, but our whole community, our technology, our post-acute carers, everyone just banding together to try to help people. So,
well, thank you for that. Lisa, I'm sorry, Paul.
No, I was done. Okay.
By the way, Paul is a little amazed today. In his neighborhood, there's a coyote who's paying a neighborly call to people in his residence. And I don't know if that coyote needs to have a referral to perhaps a wildlife preserve. But if there's anyone capable of handling that referral, Paul, I'm sure it's you and your team. Lisa, how's your life been since COVID-19? Busy much?
I have been busy, but one of the nice things about it, I'm always the eternal optimist. And like Paul, there's been a lot of good innovation going on. And, just from the personal side, it's really gotten me, and including a lot of folks, it's given us time to think about what's important and how we spend our time when we weren't in lockdown. And so I think, it's kind of helped me rethink priorities and what's important, and, hopefully lessons learned, so that, moving forward, learning from the last 18 months and taking those lessons and moving ahead.
Absolutely. And we're going to, Lisa, during our conversation, which begins in just 30 seconds, we're going to actually ask you and Paul and Marcia to share all of those lessons with us. Marcia, I know we're going to kick off in a second. I know that you are up to your eyebrows busy, but have you had any time to take a breather, do anything other than sort of dive into the life of Vanderbilt in the last 16 months?
Yes, thank you. Last summer, I was able to go to Montana. We couldn't go other places. And so it's a place I would never have gotten myself to. And it was a fabulous trip. And the culture is so interesting. We were on a kind of a resort, but it was a horse-oriented kind of environment. It was very nice. So yes, you had to take a break. You had to do some self-care. That's for sure.
Well, by the way, that's one of the first practical lessons we're already getting out of this. So we're going to kick off now. And I'd like to introduce Concha, who's the Chief Operating Officer of Aidin. Again, for those of you who joined us just now, I just want to acknowledge Aidin, your leadership, you're bringing us together. You've really have been in the forefront of amassing real-time accurate information so that these expert panelists and others who are joining us today can make accurate, informed decisions. So thank you so much for hosting this. Thank you so much for your work. And please, any welcoming comments for us?
Sure, absolutely. Well, just want to say thank you, everyone, for joining. Thank you, the panelists, especially for your time. I know how busy all of you are. For us, this is a very exciting time. We've gotten some great questions coming in through the attendees for the panelists. But it was important for us to bring the group together, especially, as we're going into different stages of COVID. We were seeing organizations that we work with across the country facing the same issues, and being the outcome-oriented company that we are, we want everyone to succeed, but we're also seeing innovation happening in silos. And so we thought this would be a great opportunity to bring those innovations to the forefront, and work truly as the Aidin community, as the hospital community, to solve some of the problems that we're all facing around length of stay, readmissions, and staff burnout. So really want to thank you all again for joining, and encourage all of the participants to please ask questions, share ideas. If there's a question Gil asks and you know that you're doing something differently and it's working, send that over. We want to hear about it. We want to talk about it. So let's make it as interactive as possible, and let's learn from each other. That I'm going to hand it over to Gil. Thanks.
Thank you so much. So let me introduce our panelists. I've had the privilege of getting to know them through our preparatory sessions for this day. They really are outstanding individuals, dedicated professionals to the field, and like many of our participants today, are representative of the greatness of this community. And as each of them have said, the readiness to embrace innovation that can improve the human condition. Let me introduce them by alphabetical order by last name. So first, Paul Pablo Aris. It's just a privilege to have you here. You're a real Renaissance health professional, I just want to add. Paul started as a nurse. He then actually went off, he became a health IT professional. He's a lawyer. He began his nursing career in cardiac ICU at Miami's VA. Obviously, you see some of the most challenging patients always within a VA system. Thank you for that. You obtained a master's in health information, and then also you went on to get your law degree from Concord Law School. So you really have a quite a diverse background. You dedicated 21 years of your career as a nurse in a variety of different senior positions. And then the last 15 years, you've been dedicated as a point person on the conversation we're about to have today. You're now the Assistant Vice President in Care Coordination at Loma Linda University Health. And for those of you who are not familiar with Loma Linda, it is really one of the prestigious academic medical centers operating. I think you're operating 6 hospitals at this point, if I'm not mistaken. You have a physician practice corporation. You have remote clinics throughout Western United States. And also, Paul, you are the author of a very well-regarded, well-used book that I recommend to people here, because it's dealing actually with one of the most frustrating parts of our work. It's titled Prevent Denials and Win Appeals, The Hospital Case Manager's Guide to Revenue Integrity. We so much appreciate your being with us here today, Paul. Thank you. Next, Marcia, it is also a pleasure to introduce you. I know you are right now at Vanderbilt in the middle of a Delta variant COVID crisis. Thank you for breaking away to be with us. We hope you'll be able to join us for the entire call. You are well known nationally for your passion in designing care management delivery models. You are looking at making sure that people have access to care, that you're centering care systems around the patient. Obviously, patients need a voice. They shouldn't just be invited to the table. It's their table. And you're one of the pioneers who has recognized that. You obviously started a very unique background that really speaks to empathy as well as technology. Where empathy and technology converge, we have our greatest potential to heal. And I want to acknowledge your role in that. You have a bachelor's in science and special education. You have a master's of science in social work. You have a PhD in social work administration. All of that makes you uniquely qualified for the roles, organizational roles and system-wide roles that you've been serving. You've been obviously the system director of care and coordination for the UCL health system, obviously one of the nation's largest. And then you joined Vanderbilt about 4 years ago, and you've taken on a variety of different functions there. Obviously, you're leading a whole strategic initiative in reducing readmission, and you're in charge of readmission strategies. So I know that you are an expert in looking at transition models across ambulatory and post-acute care. We're going to have a lot of questions for all of you today. You too, Marcia, of course. I also just want to give a tip of the hat, or a hat tip, as they say, to you in Vanderbilt. I understand yesterday, U.S. News and World Report named Vanderbilt one of the 20 best hospitals in the United States. I imagine that your department plays a role in that. Congratulations to you. Next, Lisa Graham, you're responsible for care management at Ohio State University, the Comprehensive Cancer Care Center at the James Cancer Hospital. The James is actually one of the best cancer care centers in the United States. It's known as being a center of excellence, not just in cancer care, in research. Obviously, you're dealing with important and serious post-acute care situations, people who are undergoing cancer therapy. Obviously, a lot of specialized attention needs to be given to where they're going next to continue the healing process. You're responsible for inpatient and ambulatory case management and social work, post-acute care programs, and virtual oncology initiatives at the James. And I imagine you must be using a tremendous amount of technology along with, I'll say, patient TLC in the decision-making process. I also want to acknowledge you. You're an award-winning leader. I've seen videos of you being honored by various professional associations. It speaks not only to your leadership at the James, but within our community overall. You're a nurse, you're a senior leader of the field, but you're also a researcher. And I had the pleasure, and I would recommend that if you don't mind, or at some point sharing in the chat function, you wrote a very important article that caught my attention in the Journal of Practical Oncology. And you examined 30-day readmission rates in a comprehensive cancer hospital. And it's very, very important because I think all therapeutic categories can learn from that. So you have much to add to today's conversation. I know from the basis of your research dedication that, in fact, your opinions will be much researched. So I want to welcome all the three of you to our discussion today. And I want to start off with a practical question, because I think our participants really have a sense of conceptualizing the role and the problem. So I want to shift right now in the time we have to strategies and practical solutions, if that's okay. And Marcia, because I know you may have to jump at any moment, I want to start with you. And then Paul, please listen closely to what Marcia has to say, Lisa as well, because I'm going to turn to you next. So obviously, we're here to solve a problem, and we're looking for best practices. Marcia, when you look at strategies that you're adopting to tackle readmission rates and discharges to the home, can you sort of hone for us, what are you trying to really drill down within the Vanderbilt system and say, hey, folks, we've got to consider this in terms of taking a look at what's next for this person?
Thank you, Gil. So I think first and foremost, and I know my colleagues, I hope they would agree with me, is understanding what the patient's needs are. You mentioned so many times patients come first, but what we see in many hospital organizations and certainly academic organizations is we have to get the level of care correct. We lose opportunity when we send a patient to a level of care that might not meet all the patient's needs. And I give an example of that in terms of LTAC. And I'd like to hear from my colleagues in terms of their strategies around this. Are we sending patients to LTACs appropriately and at the right time? Do we wait too long and keep them in the ICU when they could have gone to the LTAC 5 days earlier, as an example? So I think getting the disposition correct and helping the team understand why a certain level of care meets the patient's needs. Sometimes we defer to physical therapy and occupational therapy, and we have to remember that they're making recommendations. And oftentimes we see that the patient's payer will not cover a certain disposition. Maybe they won't cover IPR, acute rehab, as an example. And so we waste a lot of time, a day, 2 days, et cetera, when we really need to say, can we get the patient, here's where the benefits are, and start the whole process. And so I would absolutely underscore and reiterate that having an educated staff that is proactive and not afraid to take a leadership role with the team. Very important.
Marcia, thank you. Paul, you wrote the book on some of what Marcia's talking about in terms of taking a look at this, of the payer relationship and so forth as part of the overarching strategy. Can you add to what Marcia was sharing?
Sure. And to that point, one of the strategies that we use here when I was talking about innovation earlier was to actually add my guidelines into our assessment so that we use early triggers right inside of our EMR to determine those levels of care and when those patients should be triggering for our alternate levels of care. Like for instance, for skilled nursing, we took our top 20 diagnoses, looked at our guidelines, took the most common trigger questions or diagnoses and questions and put them right into our assessment so that we know when those guideline questions are hit, the milestones, that these patients should be triggering for that alternate level of care so that we can make that recommendation early for that early transition instead of waiting for PT and OT to make those recommendations. And if the insurance company wants to deny it, well, we have evidence-based guidelines to back that up so that they can't deny it. So we can come right back at them and say, well, you're using the same exact guidelines as we are. This is evidence-based. How can you possibly deny something that you're using the same thing as we are? And we can overturn that very quickly and get that approval to move that patient. So using the technology to help us move it quicker, but also using evidence-based guidelines to put it into your EMR. Let's leverage what we can, move it quicker, understand where they're supposed to go. That helps you reduce length of stay. It helps you reduce readmissions, and it leverages technology and using those post-acute care referral tools to package it and send it all together really helps us move patients in a much faster way.
Thank you, Paul. Now, I'm reflecting on what Marcia and Paul just shared. I would appreciate if you don't mind amplifying on this a little bit, because certainly in a well-known cancer care facility, on one hand, you've handled the acute care, you're looking at the post-acute care, and yet it's not only healing, you and the James are going to maintain a long-term relationship with that patient around the continuity of cancer care. So to some extent, your vision might have to have a sort of a slightly longer term view of post-acute care. Could you add to the practical strategies that Marcia and Paul have shared and add your sort of like experience from the James?
Yeah, so in addition to what Paul and Marcia talked about, understanding who's at risk for readmission and why is really important. And we use risk models here and analytics to kind of identify and figure out who those folks are. Our staff, because we are research focused, our staff have collected over the years lots of data about why our patients are coming back, so that we have better knowledge and are able to be more proactive in our approach to them, so that we can better prevent the readmissions that they're having. And to your point about looking across the continuum with them, not only have we implemented a lot of inpatient strategies that our case managers use, we've also kind of tried to engage our patients more in their discharge. We've developed a patient engagement tool to help patients understand what they need to know while we're going through the discharge planning process with them, so that they're just as involved and engaged as our case managers, because it's really important to engage them so that they understand what they need to know to go home safely. We've used a lot of virtual and are developing a lot of virtual strategies now, because we found that it's not just what we do from the inpatient side, but it's also what we're doing in the ambulatory side to support them once they leave. So we have been doing post-discharge calls, but we're partnering right now with a technology company to expand that and automate it so that we're able to identify and spread that out to more patients than what we're able to do by just having a resource do that. We're also looking and partnering at this point with developing other home-based strategies for home-based care. We're in the process currently, again, with all the innovation we talked about, of developing a virtual transition clinic for these patients as well, that gives quicker follow-up to those folks that are having issues before they can get back into their oncologist. And then the other big thing that we had done, and we had done this a few years back, that we continue to grow and strengthen, was our ambulatory case management program in the outpatient for these folks. They really have a lot of needs when they're discharged. Having those case managers out and assigned to all of our different cancer service lines has made a real difference for those high-risk complex patients, for our inpatient case managers to hand off to the outpatient case manager so that they can then pick up where the inpatient folks left off to kind of help continue to support them. And it's really made a difference as we watch our trended readmission rates go down. One of the strategies, I am going to put a plug in for Aidin at this point. We implemented Aidin in October of 2019. And since that time, not only has it helped our length of stay, but also it's helped with our readmission rates to post-acute partners, because I think that our patients are also making better decisions and choosing higher quality partners. So we've used a lot of technology, but we've also used our outpatient case managers to really put our arms around these patients, both in and out, to kind of prevent that readmission from happening.
Thank you. Thank you so much for that. Lisa, you really hit on so many important aspects. And I think that the three of you would agree, you have nursing backgrounds, you have social work backgrounds, you have, obviously, the three of you have case management backgrounds, and technology plays such a significant role in care today. And I think we can start from the very beginning belief that technology combined with human touch, combined with empathy, provides a higher degree of care. So I'm going to ask a question about technology, but in the background for the three of you and our participants today, just acknowledge right up front that obviously it is compassion for people that is driving ultimately decision-making, and we're using technology to enhance our abilities to care for people. So let's take that as a given. Marcia, I want to return to you for a second, because Lisa and Paul have brought up important concepts. They've talked about both innovation and technology. And, I know that hospital systems, major hospital systems, it's, on one hand, they're just dedicated to innovation. On the other hand, I know that sometimes it's hard for new ideas, new technologies to break through. But could you speak a little bit about the type of technologies that you're championing in the post-acute care setting, the ambulatory care setting, and you're using to reduce readmission rates and to amplify your and your team's skills to care for people's needs?
So I would start in terms of technology is only as good as the process and the structure that you set up to support it. Technology by itself is not effective. It's like having the smartest person in the room who has no common sense. And so I like to talk about it that way, because I often see in different organizations where they have great technology, it's underutilized or poorly utilized because they don't have the process and structure to support it. And one of the things that you have to have, of course, is rigorous staff education and retraining on all fronts. And so some of the things that we have been doing here with our post-acute partners, we first of all, we need our partners. And we also recognize that sometimes the partners, their entities, their centers, whether it's a SNF or rehab or whatever, they may not have the level of sophistication that we have in an academic medical center. Nevertheless, we have to work with them and find ways to partner and support them. I have recently started a work group with our key SNF providers, and we're going to be looking at improvements to the admission process, the referral process, and how we can come together to talk about the give and take of all of that. And we too have Aidin. I brought Aidin in at UCLA, and I brought it in again at Vanderbilt. And the reason why we have to have technology like Aidin is because of the type of analytics that it provides us. I want to know how long it takes us to start a referral after admission, how long it takes us to get to patient choice, and then to discharge. And the Aidin report structure is set up for timestamps. So I use those reports in various ways, and I use them to educate our executive team. That is very important. The organization is expecting at every moment, and I think everybody can resonate with this, they want patients discharged. For example, today we have 80 ED boarders. We have 30 patients waiting in the ED to be seen. So to say today is a hectic day is an understatement, and I have to be able to help educate the organization at the right time, at the right moment, with the right data to get us to another innovative point, whatever that might be, a new strategy, etc.
Thank you so much for that. Paul, carrying this through to you, what we're clearly hearing now is that we're using information to make what I'll call strategic decisions, and that clearly allows us to navigate each patient's situation uniquely to them. In terms of length of stay, I'm just wondering. Clearly, the desire is to keep length of stay within a respected healing stage, and then obviously look at that next step. And Marcia just talked about using information. In this case, she mentioned Aidin, using that information to sort of guide what is going on in terms of the quality of decision alongside the quality of care. Paul, could you talk a little bit about what other tools that you're using? It might be Aidin, it might be something else, but in terms of remote patient monitoring or technologies that you use in terms of tracking cardiovascular function, hemodynamics, perhaps telehealth, all of that. What are you bringing in to the system where you say, hey, to do this right, we need information, and we need information on a variety of different levels, from understanding where to send someone to understanding once they've been sent someplace, how are they doing? What comes to mind for you in your system?
Sure. One of the things that brought here when I started was an expansion of my transitional care team. I got here, I had 3 people on staff, a pharmacist, a couple of nurses, and then we now have a team of 16 different people. NPs, social workers, more pharmacists, more nurses, navigators, and then partnerships with those post-acute care providers. In my skilled nursing facilities, I have geriatrician SNFists. I also have partners with my home health companies. And with those, I also use remote patient monitoring. We have just started using in the last 4 months bio stickers and bio buttons. It's put out by a company called BioIntelligence. They developed, and there's a few companies who do this now. So they're small, they look like the size of a quarter, one's the size of 2 quarters. They go right on the patient's chest. They can monitor different things such as respirations, temperature, cough. If they're a sniff, they'll tell you whether they turn that patient every 2 hours or not. It does gait analysis. We're developing the EKG function on one of them right now. Philips has part of that that company now, so they have 10%. So they're expanding what it can do. And the company that actually does the remote monitoring does it 24/7, will alert our physicians if something is going on, or the home health company if they're at home. So we are able to prevent readmissions because we have data at our fingertips immediately. Something happens, patient gains their weight. We also send them home with scales, blood pressure cuffs, and pulse oxes, which are tied to it. There are cellular hubs that go with them, so the patient does not need to have any kind of Wi-Fi or their own phones. So it's easy for the patient. They go home already on it, so they don't need it, or they go to the SNF with it. So we've expanded our capability of monitoring. Plus, it has a dashboard. We know each patient. It has a multitude of different data sets, so we can monitor what's going on. We can see how effective it is over time on these patients. We'll monitor those patients for 30 days or up to 90 days if they're one of our bundled payment patients. So it's helping us also on our bundled payments. We're about to launch our acute care at home program. Many of these patients are going to be as part of that. So we have a long-term strategy. So it kind of all ties in together so that we have data streams from the moment they leave our hospital to the time that they spend there. It's tied into our physician communicating back to our cardiologists or our PCPs in the community, so that there is that wraparound service. But at the center is that patient, so that you spoke about that human connection. Everything starts with our navigators speaking to the patient. We do patient assessments to determine how well engaged they are with their own healthcare. We have a health coach who teaches them how to get engaged. We've improved their own self-engagement over time. That helps reduce readmissions too, because we need them or their caregiver involved, so they understand why they're getting this technology, how it's going to improve their life, how they can make changes. And we engage with that health coach over time, not just 30 days, but beyond, even up to a year with that health coach to help them get these strategies in place. So it's technology and the human aspect. It's a combination of both. And that we can see how these partners are doing because we send those referrals to Aidin. And if they have a readmission, I know it through Aidin. So it kind of all ties it together. It's a great system for us.
No, I just want to say that you're mentioning Aidin was not prepped or asked for. There's a common thread here. It's interesting for me. So I just want to pick up on that because you've mentioned some tools, and I think whenever I hear technology tools or information tools, I feel that we're getting down to practical solutions. And in dealing with length of stay, reducing readmissions, in trying to tackle health professional burnout, we can be theoretical about this. We can be aspirational about this. At the end of the day, we've got to be practical. We've got to put in place something that tells the system that, hey, we're trying to improve this for everybody, for the health professional, for the family, for the person who has a health need, and oh yes, the payer benefits as well. We're trying to bring this all together through tools. So I want to deal with this specifically and ask you how health information, like Aidin, how has it changed your relationships with your post-acute care network? And does it enable you to give them sort of direction and constructive feedback? And I'm wondering, Lisa, since you started that off, if you wouldn't mind addressing that for us in a second, because I understand it's not just that you're using a service. You're, as Paul just said, you're using that to look at outcomes and performance of that service. So what do you do with that? And how do you address them and course correct so that you're actually doing less work at the institutional end?
So actually Aidin has really helped with those relationships that we have with our post-acute care providers. Prior to Aidin, we were still meeting with our post-acute care network and the providers in that network. And we were having them share data with us and trying to have some of our own data and information to share back with them. But it was a kind of a manual process. The data was a lot of times older data, especially when we were having them submit their compare data. And so what Aidin has really helped us do is get more real-time data, more data that's focused on our organization, so that we can have more meaningful conversations about where there's opportunities to improve, and where they're doing well. What their referral rates are, which of our patients are they taking, which of them are they denying. We would hear sometimes that well, we're not getting as many referrals, or they don't feel like they're seeing as many of our patients. And one of the nice things about Aidin is that I can see every referral that was sent to them. I can see every time that they declined a referral. I can see why, and so it really helps. Solidify some of those discussions, and sometimes it's a feeling, and that feeling isn't really reality, and so we can have real discussions about what our activity is, and then it's really incentivized the providers, not just the providers in our network, but the providers that we're utilizing around the state, that look, we're sharing these quality scores, and it's out there for patients to see, and you're ranked by these quality scores, and so it's really an incentive for them to provide quality care and be a quality provider, because it impacts what the patient is seeing when we're offering that choice. And so I do think it's really helped guide the discussions, give meaningful information, and help them see where they need to improve and where they can do better.
Thank you, Lisa. Marcia, I just, we have, I'm happy to say, a very busy feed of questions coming in from our participants today, which is a credit to all three panelists that we have so many people who are actively engaged in the conversation. One of the questions that's come across is, how do we empower staff to communicate disposition recommendations versus waiting for the physical therapist or occupational therapist's recommendation? And Marcia, if you're comfortable, could you share an insight of the type of pushback you get internally from staff on those recommendations?
Yeah, that's a great question, Gil. And I would say that what has helped us the most is developing a new model of care coordination at Vanderbilt. We launched it last August. It's called Progression of Care. And the attributes of this model basically are training staff to be more proactive and engaged with their physician partners and the rest of the team. Now, that all sounds very easy to do. It's not, because when you are in a room with your peers and you have to go against the grain, even if it's a soft movement versus a harsher movement, it's very difficult to do. And so we have been spending a lot of time with staff. We had to train 140 staff in this new model, and we're almost done. We will be done in August with the final training modules. And basically the focus is on, for them, how do you talk about issues where there is a difference of opinion? How do you inform and educate and inform the team? And the example I used earlier in terms of the payer will not provide a benefit for inpatient rehab. That's one example. There's millions of others as well. But helping the staff, we demonstrate to them a conversation that is effective and productive and maintains professional relationships, and try to show them by demonstration. It's in the surgery world, what is it? See one, do one. I'm missing one part of that, but nevertheless, it's the same kind of modeling that we have to do to staff. So we're still working at it. I don't think it ever reaches perfection. And some staff are better suited to that kind of approach and stance than others. And I think everyone might agree that we have some staff that are just more task-oriented and more willing to accept what the team wants versus how to really articulate a different disposition or a different discharge plan.
Thank you for that. No, I'm listening to what Marcia just said, Paul, and this sense of getting alignment internally for each patient is both emotionally and time consuming. And then when we're dealing with the risk factor of someone sort of leaving and then bouncing back, the risk of that. And I think, you have done an exceptional job in reducing readmission rates at your institution. I think you've, since you really have been taking charge of that, the readmission rate has dropped noticeably. Congratulations to you and your team. But I want to touch on one of the other elements that has brought us together, which is staff burnout. And could you, because you were really sort of in the forefront in nursing care for many, many years. You've worked at sort of high profile institutions where people are not well. And nobody wants to be in a hospital, right? What are hospitals and long-term care, post-acute care facilities competing with? I think we'd all agree they're competing with home. So with that in mind, Paul, could you define a little bit for us your vision around reducing staff burnout? How does readmission, length of stay, and staff burnout all align? Could you kind of define it from your vision?
Sure, that's a good one. The concepts behind trying to keep your staff engaged, happy, the morale up, and still producing good outcomes is difficult. It's a leader's role to understand your staff, their motivations, what their needs are all the time. And that to me starts with communication. Really getting to know who they are and what their needs are. And then having the ability to flex to meet those needs. When the pandemic started, I think we were all trying to just figure out how do we keep people safe and still do our jobs. And I think at first we were all scrambling and things were changing week to week. We didn't know, how is this pandemic going to affect our ability to take care of our patients, let alone our staff. So one of the things that we had to do here was, how do we provide them with the equipment they needed to stay safe? Do we keep them on the units? Do we have enough space to put them where they need to? Do we send them home? Do we have the ability to keep them and let them work from home? One of the things I did was pivot and change my model midstream, something I've never done before. I have a triad model, and we do things where my case managers also do UR. I separated it for a while. It's something that I don't like to do because in the long term, I have found, at least where I work, that length of stay does suffer. Readmissions do suffer when you separate them for a long time. I found the communication between UR and discharge planning starts to get broader and broader, and your length of stay starts to get longer and longer, and your potential for readmission starts to increase, and it does suffer. But why I looked at it as, well, I can either do this or my staff burns out or my staff leaves. My staff doesn't want to work here. They're scared. I don't have the facility to keep them all safe. I can't. We kept opening COVID unit after COVID unit after COVID unit after COVID unit as our numbers kept increasing. And that was during the second surge. And so we, as a leadership team, I got my team together and said, we have to do something. So we decided to separate it, and we were turning our case managers, we had some home and we rotated them. Our social workers, same thing, we rotated them so that we had some staff here and we had some staff at home. We checked in on them all the time. We provided counseling. We provided them with the ability to have someone they could speak to. It wasn't just through EAP, but some of our senior social workers volunteered to do counseling with them some are licensed clinical social work if they wanted to. So we had to pivot and change. Once we got past that major surge, and we did this for 4 months, we said, okay, we're going to go back to our old model and we're going to do what we've been doing. And numbers started to improve again because we did see our length of stay go up. I did see my denials go up a little bit. We went from 8% concurrent denials down to 0.87 this last year. And I sort of started to climb up a little bit. Once we went back to the old model, it dropped again. But it was a hit I was willing to take because I needed to ensure my staff was mentally okay. So when I told my boss, he was okay with that.
Thank you for that candor. I think one of the great things about this panel conversation, I want to acknowledge the three of you, is in fact candor. The only way to improve health nationally is to collaborate, is to share information, is to share best practice. And Paul, you and Marcia and Lisa are really exemplifying that level of share. And I want to continue that depth of insight as we continue our conversation today. Elise, I have a quick question for you. But in the quick question, I'm wondering if you could give a little background. Paul just talked about triad. He talked about changing the systems. I've been following the chat of our participants today. There's been a lot of questions back and forth, dyad or triad. And people are jumping in. And you probably have a point of view on that. Paul clearly did. But would you be comfortable giving us your point of view? But more so, whatever answer you have, explaining to us a little bit why you went in a certain direction and why you recommend our participants really reconsider or consider the direction they're in.
So we have a dyad model here at the James. We've had the dyad model for a long time. And I think that we have stayed with that model because of it has served us well as far as understanding care progression, understanding where the payer's at and what they're wanting to pay for. One of the biggest barriers to a triad model is the communication between the UR and the case manager. And within the dyad model, that one role is doing both. And so there's a better understanding of what's going on from both perspectives while you're trying to progress the care, but also what the payer is doing from the payer perspective and what they're going to pay for. So, and understanding that insurance in depth. And so that's why we've always stayed with the dyad model. It's worked well for us. Our denial rates are low. It's worked well from our perspective when you're in a dyad, and then with us, we're service line model. So because our cancer care is so subspecialized. So we have that one case manager or two case managers on the service, having the relationship with the physicians, having the knowledge of that specialized care. And so they have been able to use that knowledge not only to help move our length of stay needle, but decrease those readmissions. And on top of that, our denial rates have stayed low. And I feel like the dyad model is part of it. So, one of the things that you have to be really careful about when you do have that type of model is to make sure that you're not, that you're resourced appropriately. And so our executive leadership, I reported directly to the executive director of the hospital, and he supports that. He supports it totally. You have to have that support because if you're not staffed appropriately to do it, it makes it very difficult. The other thing, there's always temptation to go to the triad model, but what we have tried to do is find simplicity in the work and cut our administrative burden by the use of technology, and always looking at our role and tweaking it where we need to, so that I'm making sure that my case managers aren't spending too much time in the administrative clerical piece and not at the bedside with the patients, because being at the bedside with the patients is the most important thing in being an effective case manager and getting the outcomes that we want to see. And so, we're always looking to find that simplicity and cut our administrative burden wherever possible so that they are at the bedside as much as possible.
Lisa, thank you for that. Just a quick sub question on that, if I could.
Gil, if I could just put a point
Please,
of
Paul. Yes, please.
point of clarification. When I meant the triad model, I meant a case manager assistant, a case manager, and a social worker. So
Thank you. Paul, thank you for that clarification. Very, very important. And Lisa, one of the questions that popped up as a result of your background is a little bit of on the dyad model, what is your RN to patient ratio? Would you mind just giving us your sort of like your number?
So it depends. It depends on the service, basically. Our surgical services, the case managers can handle a little more. Our hematology services as well. Our medical oncology services, we have to drop our ratio because of the psychosocial needs of those patients. So we also have to look at it. Not only are we service line and not only are we dyad, but we also have to look at where we have an oncology population and we're providing a lot of specialized care. And we do surgeries and things here that are research-based that everybody else isn't doing. And we have to keep that in mind too as we staff. So our overall average is about a 1 to 10. But it can be a little less than that if you're on a medical oncology service. It can be a little more than that if you're on a bone marrow transplant service because those patients stay longer. So we really look at the patient complexity as we're also looking at, the workload. And we take into account all kinds of factors, Gil, when we're looking at it as far as review activity on the services, discharge activity, post-acute care use, patient psychosocial needs. And so all of that plays into how we staff. But that's why I say you have to be really cautious about and have senior leadership support to keep those numbers and those ratios where they need to be if you want to do it effectively.
Lisa, thank you for that. That's a good background for people to consider that there is no one size fits all. Clearly what I've heard, I think everybody's heard, is it really depends on the patient type and the department and specialized services. We thank you for your candor on that. And Marcia, you really are, from your UCLA, now Vanderbilt experience, you've dealt with the big systems on one side of the country, on the other. I think that one of the most challenging things that everybody on this call deals with is prior authorizations. The burden of that, the surprise of answers. Paul talked about these 20 factors or best practices his system brings in to try and limit that argument with payers to some extent to really deal with what the patient needs and address that. But would you mind talking a little bit about the role that prior authorization plays emotionally, psychologically, in terms of staff burnout, time spent? And actually, I would imagine people are very committed at Vanderbilt. I know how committed they are to the patient. I think your CEO, Jeff Bolser, has said that he sort of views each patient as a universe unto themselves. So I imagine that you have a lot of universes that are dealing with prior authorization. Could you talk a little bit about the frustration and the push that you and your team have to go against?
So if you're defining a prior authorization as authorization for post-acute care, that's what I assume that you're meaning. Okay. So it is by and large the most frustrating part of our transition process, I think. A couple of reasons. The authorization process at Vanderbilt is done by the post-acute care entity, not by us. And so we are reliant on the SNF or the inpatient rehab facility or the psych facility to secure that authorization. And when they are not successful in getting the authorization, they can ask for a peer-to-peer, which is very useful and oftentimes successful, but it takes time. And we just had a case this week where we were trying to get the patient transitioned. It's a long story, make it short. We lost the IPR bed. The patient was placed on hold because we could not secure we couldn't identify a date for the discharge, and we lost the bed and had to have the authorization restarted. And so it's those kinds of things, and it's very difficult on the staff, but also on the organization, because they do not understand the process entirely. They might understand some parts of it, but not in a very deep and comprehensive way. And so, we say to our staff, you've done the best you possibly can. We look at cases all the time and say, let's do a drill down and determine what could we have done different on this case? What should we have done earlier? When should we have raised the flag, etc.? And I think that's what you have to. You have to be able to give feedback to staff, but in a non-shaming way. They are not going to respond if you are constantly in their ear about what they should have done better.
Listening to the three of you, and I'm going to turn to a final question to the three of you. You have nursing expertise, social work expertise, legal expertise, systems expertise, digital health and health technology expertise, health information expertise. The three of you cover the gamut of the system. You're looking at innovation. You're looking at the emotional motivation of staff to continually come in every day and do their best for each person who enters your doors and aspires to leave in a healthier platform. I think that it's a very appropriate to acknowledge you and all of our participants today for your dedication to people's health. And we also know that when a member of a family is sick, indirectly the entire family is carrying the burden of that illness. So I want to thank you for the leadership that you exemplify for our community. So I want to ask a final question. I'm going to start with Paul, and obviously the three of you will address this. If you could look at the technology that you have available today, the technology you hope to have available soon, if you could take a look at the challenges that you're facing, if you were to say, I have the power to make this specific change, this advance to improve the system, to improve care, to effectively, what we'll say is ideally reduce the length of stay, but ensure people are healthy, reduce readmissions, and obviously deal with the emotional needs of colleagues. What one or two changes would you make tomorrow if it were your decision? Paul?
I think the first thing I would do, and I think something that we try to do by legislation, but I think it's impossible, and we learned it, is a fully integrated healthcare system, right? In which the interoperability of communication was established, where we had one platform where everybody spoke to each other and information flowed in a continuous loop where everyone had that information. I worked in Maryland. We had what was called CRISP, Chesapeake Regional Information Sharing Platform. It's probably the best one I've ever seen, where we had a lot of information that was there to use to be able to share among different healthcare systems. Hopkins, University of Maryland, I was at LifeBridge. We were able to share quite a lot. So it helped us help the patients and put their stories on there. We could develop care plans with the help of their patients and their.
That's great. That's great, Paul. Thank you. Health information shared certainly speaks to your background, your leadership in health information as well. Thank you for that. Lisa, your perspective, taking from what Paul said, he owns essentially interoperability with the ability to access information. What change would you make to the system tomorrow that you think would make a vast difference in the subject matter that we're discussing today?
So I totally agree with Paul. The fragmentation of the communication across our post-acute care continuum and our payers is a huge barrier to care. And I don't want to dwell on that because Paul talked about it. But the other thing that you brought up was another thing that is really on my list as far as the prior auths. We have to change, and it could be by legislation. I start looking at technology. It was a beautiful thing when the waivers came out and we didn't have to prior auth every sniff. It was like manna from heaven. And but that's going to go away, and we're going to be back in that same boat. And so the prior authorization process is broken. It takes a lot of time. It's a lot of administrative burden on my staff. And I think that using and starting to look at utilizing artificial intelligence tools to automate that process, to be able to time it and speed it up. Payer delays are a large issue with us, and they cause an increase in length of stay. As Marcia said, it causes us to lose beds in facilities. And it's not what's best for the patient. The patient needs that new next level of care and needs to start their rehab. They don't need to be sitting here at our hospital not getting the rehab that they need. And so
That's great.
I would have to change the prior auth process.
Thank you. Thank you for that, Lisa. That's a key tip. Marcia, first of all, I want to thank you for staying with us. What do you think?
So I would say very high level. Paul, agree with you totally. Lisa, absolutely. Then I would add one more piece, and communication for me is absolutely the critical factor. And then I would take it locally within the organization. Our systems of communication and all of the changes, when we think about how fluid these transitions are, and even the care plan, how fluid that is, and the communication, sometimes I just pull my hair out and say, how could somebody not know this was happening, or why didn't they get the update, or whatever it might be. And so I am very interested in improving and increasing the level of communication with accuracy.
Thank you. I'll tell you, there's a theme through all three answers. I want to thank you for them. Collaboration, putting the patient first, recognizing that healers really desire to heal, make it easier for them. I want to acknowledge the three of you for jumping out of a very busy life to jump in and share with us your experience and your insights. Thank you so much, and thank you to our participants. With that, I also want to thank Aidin for their leadership in bringing us all together today, to inviting our participants. I return it to Aidin to have the closing words. Concha, thank you so much for bringing us together.
Yeah, Paul, Lisa, Marcia, amazing. Thank you so much. You guys are thought leaders. I've learned, I know, a tremendous amount. To all the participants, thank you for your engagement. If you do have any questions, please feel free to send them over to me. Most of you should have my email, and I can direct you, connect you, as it's appropriate for organizations to grow together and, solve our challenges together. And Gil, thank you for fantastic moderation. Appreciate you, managing everyone. So thank you all for your time. Please don't hesitate to reach out to me if you want to get connected to any of the organizations or the speakers.
Contra, again, thank you so much for bringing us together. And again, Marcia, who's back running around with the clinic, we thank her as she's running around. Lisa, incredible. Paul, incredible. Thank you all for joining us today. Goodbye. Be healthy.